Good morning, everyone. Can you all hear me? Okay, good. Well, this is our summer series, so we're a little bit light today, but that's the reason why we're doing it. It's a summer series on care of the agitated patient. And this is the third of the 4 sessions that we've offered for Grand Rounds this summer. The first one was around, we learned a lot from Dr. Cohen in the emergency department around illicit drugs and what's happening in our community around some of these synthetic drugs that are coming in and how we manage those patients in the emergency department and in crisis. We learned from Dr. Joshi and Reggie Bannerman around how to care for a patient that's aggressive or mentally ill. We learned about the manifestations from Dr. Joshi, and then how do we manage and identify these patients that we may see in the cafeteria and one of the patient units or in the emergency department. And today, I'm very, very pleased that we're going to hear from our very own Dr. Lee Beers around what's happening in the community and what can we do differently in the community and how do we identify some of the at-risk patients. So this is the third of the 4 series. The 4th series will be on July 27th. Diane Daly will be joining us from Fort Worth, Texas, and she's going to come in and talk about their experience as well in the community. So today, Dr. Beers' talk is very timely, and we'll really, I think, we'll learn a lot from her. So thank you so much, and I'll turn it over to Linda.
Very nice. Thank you so much. I have the great honor of introducing Dr. Beers. Our speaker this morning, Dr. Leanne Beers, is Associate Professor of Pediatrics and the Medical Director for Municipal and Regional Affairs within Children's National Goldberg Center for Community Pediatric Health and Child Advocacy Institute. She's also the Director of the DC Mental Health Access and Pediatrics Program and co-director of the Early Childhood Innovation Network. She oversees the DC Collaborative for Mental Health and Pediatric Primary Care, a public-private coalition that serves as a catalyst to elevate the standards of mental health care for every young person in the city by increasing primary care provider capacity and achieving systemic policy change. Dr. Beers earned her medical degree from Emory University of Medicine and completed a pediatric residency at the Naval Medical Center in Portsmouth, Virginia. Prior to joining Children's National, she was a general pediatrician at the Naval Hospital in Guantanamo Bay, Cuba, and the National Naval Medical Center in Bethesda, Maryland. Dr. Beers has held numerous leadership positions in the American Academy of Pediatrics, and she serves in a wide variety of leadership and advisory positions within the Washington, D.C. community, including co-chair of the Mayor's State Early Childhood Development Coordinating Council. She's on the editorial board of the professional publication Pediatric News. Her clinical and research interests include adolescent pregnancy and parenting, the integration of mental health and pediatric primary care, the impact of adversity and stress on child well-being, and advocacy education. Please join me in welcoming Dr. Beers.
All right, thank you, everyone. I'm really grateful to have been asked to come today to talk with all of you about really actually many things that we've learned through the work that we've been doing in the community and how some of those lessons might apply to the work that we do here at Children's National and how we might think about an approach to providing patient care that looks through things through a bit of a different lens. So I'll go through quickly the goals and objectives for today, and then we'll get to it. So the first goal and objective for today is to really talk about the impacts that a history of trauma can have on behavior, including aggressive and agitated behavior and health outcomes. And I think that this is something that both through this series and actually through some other series in Grand Rounds, we've been talking about in a variety of ways. I'm not actually going to go super deep into the science of this because I think that we've been hearing about this in a lot of different places, but what I really want to do is talk about how that science impacts how we think about how we deliver care and how some of the lessons we've learned as a field from other social service agencies and mental health agencies can really be applicable here in a more traditional healthcare setting. And so then with that, I want to talk about the importance and essential components of taking a trauma-informed approach within more broader healthcare settings, and then identify opportunities to implement trauma-informed approaches to care within our health system. So a couple caveats, this is part of a series, right, of how to manage the agitated patient. And so I want to be sure that I'm clear, that everyone knows that I'm clear as we talk, that the management of the potentially or actively agitated patient is very complex and challenging, and it's very multifactorial. There's a lot of different things that play into it, and I think the lens that I would like to take today is really thinking about how do we think about that from a systems standpoint, and how we approach the patient to even potentially prevent some of these incidents from happening. I think I also want to emphasize that I'm very clear that the safety of our patients and staff is at the highest priority, but there are often things that we can do and be thinking about differently that can impact how we care for the agitated patient, or hopefully prevent circumstances from occurring in the first place. So I'm going to walk through two very simple, basic case studies. These are really just to kind of get you thinking about, I've deliberately kept them pretty simple, but they're really to kind of get you thinking about patients that maybe you've seen in the clinical setting or you've seen other places in the hospital, and think about how these circumstances arose and how you felt about it, how the staff felt about it, how people responded to it as they went along. So the first one was in primary care. A 2-month-old infant was brought into primary care during an after-hours time with the chief complaint of thrush, pretty simple complaint by the mother, in the company of 2 siblings. Patient came, was checked in, pretty uneventful, put in a room. Less than 10 minutes later, screaming from the hallway. Mother was very upset, yelling that she'd been waiting way too long, slammed the door, and stormed out of the clinic. So patient 2, this is an inpatient, a 17-year-old obese female who was admitted to the PICU for initiation of bypass. This young woman has a history of multiple long-standing medical complications from her morbid obesity. She has a history of poor compliance and poor follow-up. During the inpatient stay, this young woman was very poorly communicative, frequent outbursts, really difficult. The staff found her very difficult to talk with, to engage in care, to communicate with, and she frequently got upset and mad. So, you know, I just think for a minute, these are very simple case presentations, but I'm sure everyone has seen similar patients in their own settings and in their own clinics. In both situations, staff felt very frustrated. They felt like, what is going on? There was a tendency of like, why is this happening? You know, why is the patient acting like this? And I think in the field of trauma-informed care, there is a phrase that's very commonly used that I'll talk about today. And the phrase is to provide better care to patients, we have to start thinking about not what's wrong with you, but what happened to you. And so in that vein, I want to kind of give you part 2 of these case presentations where instead of for these 2 patients thinking, you know, what's wrong with you? Why are you acting this way? It's more about what happened to you. So patient A, in this circumstance, we actually called the patient on their cell phone and said, you know, we're really ready to see you. Do you want to come back to clinic? We'd be happy, you know, if you're willing and in that place, we're willing to see you. So the mother came back, and actually during the course of that, we elicited a bit more history. First of which was that the mother is working in a full-time job where she doesn't get paid sick leave. Her baby's been sick on and off for the past month. She's had to take multiple days off, and her finances are very tight, and without working full-time and getting paid for full-time hours, she can't afford to pay for basic necessities for her family. So that was causing a significant amount of stress. The other thing we learned is that she's a victim of domestic violence, and that the night before she came to clinic, she'd been sought out by the baby's father's new girlfriend who assaulted her out in the community. She was in the process of getting a restraining order and all sorts of other pieces, but she was feeling very activated and very worried because this other sort of community member was seeking her out and trying to find her and behaving aggressively. And so that put a different light on her behavior in the clinic, and in fact, when she came back to clinic, was very calm and very appreciative and very accepting of the care that she received for her child. So for patient 2, this is an inpatient, and we have a wonderful, wonderful social work department, and they really took the time to sit and talk with the patient, talk with the family, and elicited some additional pieces of history that were a lot more long-standing in this case, but that really did impact the patient's behavior and physical health as well. This young woman had a long history from a very young age of having been physically and verbally abused by her mother. Her mother herself has a history of severe mental illness. The patient, as a young teenager, and her younger sister together actually often engaged in acts of prostitution in order to get money to pay for basic food and needs in the family. This was sort of something that happened on an ongoing basis. And that in addition to the chronic medical conditions this young woman suffered from, she often felt very depressed and very panicky, and that she had a very high level of anxiety at all times. And so as I go through the talk today, I just want everyone to kind of keep these cases in mind and think about how, knowing this information, how we might respond to these patients, and maybe how we might respond in a supportive way, how we might build on some of the things we're already doing in our clinics and in our care settings, and how we might do things a little bit differently. So I would like to take credit for the things I'm going to talk to you about today, but really much of this comes from this very nice report from HHS, U.S. Department of Health and Human Services, out of SAMHSA, focused on guidance for taking a trauma-informed approach to care. And this is, full disclosure, there's not a lot in the traditional literature about this. This is not something that is well studied in an academic way, this systems approach to care. However, there is a lot in the traditional literature, and there is a strong scientific base for regarding trauma and how that impacts behavior and how that impacts health. So this report really focuses on a lot of that research. It focuses on a lot of practice-generated knowledge about trauma interventions, and as well as lessons that are articulated by survivors of traumatic experiences who have engaged with care systems on a regular basis. I think the other caveat as we talk about this is not necessarily a report about how to prevent aggressive behavior in patients or how to manage aggressive behavior in patients, but it's really a report about how to provide better care. But it's also one of the things that this approach really can do is help decrease those incidences of aggressive behavior. There is a wonderful quote. There's actually a lot of really nice quotes that I'll sprinkle in through here. And if I don't attribute the quote to anywhere, it comes from this report. But there's a lot of really nice quotes, quotes in here. And this one is that there's an increasing focus on the impact of trauma and how service systems may help to resolve or exacerbate trauma-related issues. These systems are beginning to revisit how they conduct their business under the framework of a trauma-informed approach. And again, these are lessons that really first were learned in very traditionally community settings, traditional mental health settings, but it is becoming clear that they are very applicable to more general settings, such as the general healthcare setting as well. And actually, again, while there's not a lot in the traditional literature about this, other program evaluations and work that SAMHSA has done has identified that in many settings, applying this approach institutionally has actually reduced the need for seclusion and restraint. And so it's reflective of the fact that while we're providing better care for patients doing this, we are also addressing some of these issues that we're seeing of the really increase in aggressive and combative behavior. And so again, as we go through this, because I'm thinking about this from a systems level, I want folks to be thinking about what are the strengths. There are many things that Children's is really doing very well in this area, and many things that ways we may be taking a trauma-informed approach without even fully realizing that we're doing it that way, and many places where we're doing that very deliberately, but also thinking about where are opportunities for growth. So again, I'm not going to go deep into the science about this because that's been done in other settings, but I do want to level set and define what trauma is and what trauma means in this particular setting and in this context. The definition used in this report by SAMHSA is that there's sort of three key components. There's the event, there's the experience, and there's the effect. So individual trauma results from an event, a series of events or circumstances. So again, that can be a single event or it can be something ongoing that's experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. And I think it is important to think about it this way because there are several components of trauma. Two people can experience an event very differently and have very different reactions and effects from that. And so to really be trauma, there has to be an event, the experience of the event by the individual, and the effects from that experience. So I'm going to talk through those in a little bit more detail. So, you know, the first component of this event, there are a variety of different types of things and experiences that can be considered traumatic. You know, a key core component, of course, is the actual or extreme threat of physical or psychological harm. I think some of the things that probably immediately come to mind are domestic violence and child abuse. That is something that immediately comes to mind. I think some things that probably come to mind a little bit less, but that have actually been demonstrated in the literature to have traumatic effects are living in the context of neighborhood violence or in the context of family conflict in the home. And then two other things that probably are even less thought of as traumatic, but again in the literature have really been demonstrated to have traumatic effects, are living within the context of having significant resource insecurity, you know, feeling a sense of physical or psychological harm of not being able to actually provide adequate resources, and the experience of discriminatory treatment or racism. Both of those things also can have very traumatic effects and impact on a patient or a family. Severe neglect, of course, as well, something that can have very traumatic impacts. And again, we've talked about this earlier, but trauma can be something that is a single event. Certainly, unfortunately, we've seen some of these events in our national news of recent, a single event that's a very dramatic traumatic event, or it can be something that's ongoing and chronic over time. And there are you know, patients and families can experience those things differently depending on whether they're acute or chronic, but the important thing to know is that trauma can be either. So then the next piece is the experience. You know, I'll share a slightly personal story. Actually, there was a teacher in my daughter's school last year who was convicted of sexually abusing a child. And so that was a very traumatic event for the school, and there was a lot of work with the parents in the school to help them understand that. And one of our colleagues came in and talked to the school, and one of the things that he said was, you know, this event is a terrible event. This event is not necessarily going to be traumatic to your child because it depends on how we respond and how your child experiences it, because the trauma is really about the event, but also the experience and the effects. And so I think that's an important piece, is that trauma is really impacted on how an individual assigns meaning to the event, and that is mediated by a lot of different things. Trauma is also very much a situation of power differential, and so often the greater the experience of power differential, the greater the sense of powerlessness and questioning, and the more likely that traumatic event is to have impact on the patient. It's also very much mediated by cultural beliefs, religious beliefs, social supports available, the developmental and intellectual stage of the individual. So there are a lot of different components that impact how an individual experiences a traumatic event. And again, that's an important thing to realize, because when we think about our patients and families, you know, two people may have undergone exactly the same experience, and we say, well, this patient's doing just fine with that. Why is this patient responding so aggressively or so unusual? You know, why is their behavior so out of control? And it is because different people, I was warned that this might happen, different people respond to events in different ways. There we go. All right, perfect. And again, whether or not a traumatic event is acute or chronic really can influence the way a patient experiences those events. If another common analogy used in the field is this sort of fight or flight thing. And so, if you're the zebra running away from the lion, that acute experience of stress of, oh my gosh, this lion is coming to eat me, I need to get away, that is a very stressful event. But then the zebra gets away from the lion, they're in their pasture, they're happy, they're fine, things go back down. Whereas if you have a situation where, child is living in a chronically conflictual setting, that feeling of fight or flight, that feeling of anxiety and fear doesn't really ever go away. And so that has a sort of longer and more persistent effect on behavior. And then the final component of that definition of trauma is the effects. Again, like so many things, these effects may be immediate. You may see them right away. They may be delayed. We may not see them right away. They may not come up, particularly for younger children, they may not come up until even years later. Some of the things that you can see, some of the effects you can see in patients and families who've experienced traumatic events, and experience that in a traumatic way. They can have difficulty trusting and benefiting from relationships, and applying that to the healthcare setting, that certainly can impact how they engage with the patients and staff here at the hospital. If they are have difficulty entering into trusting relationships, that includes relationships with the healthcare staff. They can have disrupted cognitive processes, disruptions on memory, attention, and thinking. One of our earlier grand rounds talked about this in depth and how that can impact school performance and behavior, and of course those impacts can be really cumulative. Again, something we've talked about in other talks and other settings, but the trauma can actually increase your risk of chronic health conditions. There is a well-known sort of seminal study, very large study done by Kaiser, looking at a large population of middle-class adults and asking them this standardized 10-question questionnaire about have they experienced any one of these 10 adverse childhood experiences that sort of fall in the categories of abuse, neglect, or household dysfunction. And a couple of things they found. One was that a very large percentage of adults who were living in sort of very middle-class, unremarkable settings had experienced adverse childhood experiences as children. A large percentage of them had experienced more than 2, and that the more adverse childhood experiences you had been exposed to, the greater your risk of poor psychosocial outcomes, but also the greater your risk of poor physical outcomes. So things like hypertension, heart disease, obesity, and so the experience of adversity and trauma doesn't just impact behavior, but it does also impact poor health. And I think that's something for us to think about, in that means that patients who we see here repeatedly in clinic in our health settings who are having chronic exacerbations of their health conditions, trauma may be a component of that, and that's something important for us to be thinking about. And then really relevant to this series, 2 of the other effects that you often will see from patients and families who've been exposed to trauma and adversity are an inability to cope with normal stresses and strains of daily living. So the process of parking in a parking lot and coming and standing in a long line. No, I understand. It's normal stresses and strains of daily living. But those things become more important, and they become harder to manage when you have this background and this history of trauma. Patients and families who have experienced trauma also can have a greater inability to regulate their behavior or control the expression of their emotions. And again, these are things that we see in aggressive or agitated patients. I think about all the times I've seen this, and so often the comments from all of us in the staff are like, what just happened? Like, things were fine, and then all of a sudden, things were not fine. And patients and families who have been exposed to trauma really do have a harder time regulating their behavior and emotions. And so I think that there's a lot of overlap between these 2 areas. So again, as I said, I'm not spending a lot of time talking about the science of this, but this is, I think, a really powerful visual representation of the impact that trauma and adversity can have on the brain. On this side here, you have a PET scan from a brain, a research subject who has had a pretty typical life experiences without exposure to trauma or adversity. This is a PET scan from a research subject who has experienced abuse and neglect. And you can see that there's a pretty dramatic difference in activity between these two brains. And again, this is like just a tiny little snapshot of the science, but just a reminder that trauma and adversity does have neurobiologic effects on the brain and on the developing brain, and that when we're thinking about how we care for patients who've been exposed to trauma, that's an important thing to remember, that it's not something that the patient can necessarily, or family can necessarily turn on and off at will, but that there are sort of chronic and persistent neurobiologic effects from the trauma and adversity. Okay, bye. In a moment. There we go. This one was going to be hard for me to talk off the cuff. And again, then I want to take a second to remind everyone about the prevalence of trauma and adversity, because again, you know, we're kind of trying to think about why are patients in our health settings, why are they getting agitated? Why, you know, what triggers it? Who can we predict? And when we look at the prevalence of trauma and adversity, I talked about the ACEs study. All this data is from a nationally representative study, actually, the National Study of Child Health. And in this study, very large study, almost 50% of children had had at least one adverse childhood experience. And almost a quarter had had at least two adverse childhood and family experiences. Looking at state data, DC and Virginia are a bit higher than the national average in that. Maryland is actually a bit lower than the national average in that, but regardless, you know, even 20%, that's a lot of children and families who have these experiences in their background. A couple of other things I want to point out to you, there's so many things we'd like to be first at in the nation in DC, but there are a lot of things we don't like to be first in. You can see here, DC has actually the highest rate of children and family who were the victim or witnesses of neighborhood violence. It's a little over 15% of the children and family in our cities are victim or witness to neighborhood violence. And the other one where we are at the top here is death of a parent. 7% of our children in the city have experienced the death of a parent. And so when you think about the patients and families coming into our hospital setting, it's important to remember these statistics and remember that these things are more common than we really probably realize. They're not things we typically ask about, and they're not things that patients and families are typically going to volunteer. And we'll talk about this in a moment, too. I also want to make sure I point out that this is a nationally representative study. So this is not just about our patients and families, but it's also about our staff and our team members, because they have the same experiences as our patients and families. And so I think that's an important thing to think about and remember. All of these concepts that we're thinking about for patients and families are also really important to think about in the context of our staff. So lest I depress everyone, I want to talk for a few about what we can do about this, because there are actually ways and approaches that as a system we can take that have positive impacts on these things. That this is not just this is a horrible, terrible thing and there's really nothing we can do. There are ways that we can create supportive environments for patients and families and staff actually who have experienced trauma in their history. And so the SAMHSA talks about the 4 R's. A program, organization, or system that's trauma-informed realizes the widespread impact of trauma and understands potential paths for recovery, recognizes the signs and symptoms of trauma, responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. And we'll talk about each of those as I go along. So I'm going to kind of walk through each of these 4 R's. The first is realization, and that clearly is something that as an institution is happening. I mean, that's reflected just in the number of educational sessions that have been happening over the recent months and years about thinking about trauma and thinking about adverse childhood experiences and thinking about adversity and how that impacts individuals and community. It's realizing, as we're doing, that trauma-informed approaches are not just relevant in traditional mental health settings or traditional community settings, but across all social service and healthcare settings. It's also realizing that, clearly in treatment settings, particularly mental health treatment settings, trauma needs to be identified and addressed, but it also is something that can really be incorporated into more prevention settings. And that realization that, patients, family, staff, all can be affected by trauma, and that often we're just not aware of that. And again, a great quote from a group that does a lot of work with health systems in particular called the Sanctuary Institute, which I loved and I thought was really apt, that what we identify as maladaptive behaviors are really misapplied survival skills. And I think the context for this is if you think about a patient who is exposed to chronic and unremitting trauma, having a short fuse, having a protective response to things, that may be adaptive to them in certain settings. And that's really hard to turn on and off. When you have that activation at all times in your home or your community, that's really hard to turn off when you walk into a health setting. And so things that we identify as maladaptive may be survival skills that a patient or family has developed in the context of the setting in which they live. So trying to think about behaviors in that way, and trying to think about, just like with any medical condition, if we understand the root causes, we can better treat it. This is the same thing. So the next piece in taking a trauma-informed approach is, we've got the awareness. Now we need to be able to recognize what those behaviors are and how trauma might impact the behaviors that we're seeing. So education and training for all staff is really important. This is not just a provider training issue, but this is really every single staff who works in our hospital interacts with patients, and every single staff can have an impact on a patient and family experience, as our institution has really been very eloquently focused on for a long time. Field supervision, so really making sure, as we have, that there are experts within the institution who can talk about these things with patients and staff and help them make sense of behaviors and events that are going on. Trauma screening and assessment can be very helpful. I'll talk about this briefly a little bit down the line. It's not the be-all and end-all, but in certain settings, screening for traumatic events can be a helpful thing to do. And just remembering, as I said, that patients, family, and staff may be, we don't know under any particular circumstance, but they may be living in a state of constant anxiety and activation. And so before they even walk in the doors of our hospital, they are feeling agitated. And so remembering that in our interactions, that we may not, we may not be seeing the first 80% of the buildup. And that may be perhaps why sometimes we feel like, I don't understand why this happened, because we didn't see the first 80% of what was happening in this patient or family's life. The next phase is response. And again, that really involves staff at every level of an organization or of a division or a department. And it not only includes response for patients, but it also includes support for the workforce. Again, I'll talk about that very briefly towards the end, but that recognizing that our workforce not only may have experienced trauma in their own lives. Responses, like anything, it's going to be more effective if it's very deliberate and planful, so that we can really take a coordinated and comprehensive approach. And the response, and these are very universal principles in many ways, but the response that leads to a trauma-informed approach creates an environment that enables safety, trustworthiness, transparency, peer support, collaboration, empowerment, voice, choice, respect for cultural, historical, and gender issues. And these are very universal principles, but they're very applicable in this setting. And then the final piece is resisting re-traumatization. So remembering that patients are patients who've experienced particularly significant trauma and adversity are often living in a place where they have significant power differentials and where they have a significant lack of control over their life and the things that are happening in their life. And so resisting that re-traumatization of taking further control away from them in the healthcare setting. You know, sometimes we have to do that, but when we can engage and empower patients to be participants in the care, that's good patient care for a lot of reasons, but this is one of the reasons. This was another quote that I thought was really great from the report. It says, organizations often inadvertently create stressful or toxic environments that interfere with the recovery of clients, the well-being of staff, and the fulfillment of the organizational mission. And so, you know, the important piece here is inadvertently, but it comes back to that response, and really as an organization thinking planfully about how do we respond to families recognizing that there are high incidents of families who may have been exposed to trauma and adverse events in their lives, and staff as well. I think the other piece that's really important to resisting re-traumatization is thinking about how we adopt a prevention framework, and how do we maintain and create systems that are really supportive and that aren't stressful and escalating. Because again, we don't, you know, if a patient is 80% activated before they even walk in our doors, we don't know at what point or what thing is going to set them up. It's like that patient in primary care. They had been in the exam room less than 10 minutes. You know, it wasn't what had happened during that sort of waiting time in the exam room. There was something that happened in that lead-up time, most of which happened before the patient really walked in the doors. But it's thinking about how we really maintain systems that are supportive from the second someone walks in our door. And I think this quote didn't come from the Power of One, but I think it is really reflects the philosophy of the Power of One that we've been doing here at the hospital for a long time, which is one does not have to be a therapist to be therapeutic, and that every person in the hospital really can impact the patient experience, and every person in the institution can really take a trauma-informed approach to how they interact with patients and families. And again, I want to talk for a second again about staff wellness, because I do think that this is an important component of taking the trauma-informed approach to care that often gets forgotten and overlooked, because we are very singularly focused on our mission, and we are very focused on taking care of patients and families, and we sometimes forget that to do that, we have to make sure we're taking care of our staff as well. You know, as I said, those statistics I showed you are nationally representative statistics, and so that same 50% of children who have had at least one adverse childhood experience in their history, that is the same for all of our staff in our institution. And remembering the same impacts that trauma has on our patients and families can have on our staff, and it may impact how, and you know, our staff are wonderful and highly functioning, and so most of them have really found ways to compensate for that if they have experienced effects of trauma from their history, but it may impact how they can manage the day-to-day stresses or how they relate to patients or other staff. And so again, thinking through that lens and thinking about, could this be a component of what's going on, and is there a way I can manage my system a little bit differently? The other important piece, which again I think we've given the high rates of trauma, we do see is vicarious trauma from our staff, also sometimes called compassion fatigue. But if you have a staff member who is really constantly and persistently talking to families and learning, and as institutions start to implement trauma-informed approaches, they start to ask about these things more, and they learn about it more, and they hear about it more, and that can be very traumatic to staff to actually hear these stories over and over and over. They're terrible stories, and they're upsetting. And so remembering that our staff can also be experiencing vicarious trauma just through caring for patients and families who've experienced traumatic events. And the effects of this vicarious trauma can be very similar to the effects of directly experienced trauma, and can manifest in many ways, from sort of numbness and just kind of blocking things out to feeling very angry or mad or upset. And so thinking about how that component plays into an approach, and making sure that staff have access to support to help support them as they work through that. So again, I know lots of the talks we've given have talked about all the hard and the negative things, and I don't want us to leave the talk, I don't want us to leave the morning thinking that there's nothing that can be done. As I said, this is one of my favorite quotes these days. I feel like that's a lot, actually, that it always seems impossible until it's done. And so sometimes just taking a few small steps can push you know, a project or an individual or a system in the right direction. And then next thing you know, you're at the end and you're like, wow, look what we've done. This is one of my favorite quotes these days. I include this in a lot of talks. SAMHSA talks about if a system wants to, or a division or a clinic wants to implement a trauma-informed approach to the way they do things, there's about 10 key elements. And again, these really come from the business and the implementation science literature and are walked over to this work. And I think as an institution, we have a lot of strengths in a lot of these areas, and that's a really good thing. You know, first is really strong governance, strong and supportive governance and leadership, supportive policies, very deliberate policies, thinking about including a trauma-informed approach in those policies and being very deliberate about how you include that. Engagement and involvement, and this really is with the patient and families and with clients who have directly experienced trauma and then also interacted with our systems, and really hearing their voice and hearing the things, you know, what has helped your care, what has made it harder, and really involving those who have directly experienced traumatic events in that discussion. Cross-sector collaboration, you know, again, through the work that we've done in the community, we interact with people all the time, every day, who are doing a really amazing work in this area and doing things that we wouldn't ever really be able to take on as a health system. But it's those partnerships together. There was, for anyone who reads the Post, there was a great column today about an organization called Life Pieces to Masterpieces, and I encourage you to read it. It was very relevant, actually, to the discussion today, but it really talked about, it's an organization down in Southeast DC where that work with young boys in the community and through art. And they work with them to develop art projects and develop their creativity. But it talked a lot about how, you know, so many of the children who come through this program really have experienced trauma. They talk about a little 3-year-old boy or a boy who came through the program that was expelled from pre-kindergarten when he was 3 for behavior issues. And when they dug deeper, it turns out that the behavior issues were really that he kept falling asleep in class. And when they delved deeper, the reason he was falling asleep is because he wasn't sleeping at night, because his neighborhood was so loud and there were so many gunshots in his neighborhood that he couldn't sleep through the night. And so really kind of there are so many wonderful community organizations, and there are so many wonderful partners out there, and we've engaged a lot of them through the work that all of us have done in many ways, but really thinking about those cross-sector collaborations and how do we use those to build on the strengths that we have internally. Thinking about screening, assessment, and treatment services, those are areas where we're very strong here, of course. Our mental health services and treatment services that we offer through the hospital here are, you know, world-class. Training and workforce development, again, this is a good component of that, but there are so many aspects to that. Thinking about progress monitoring and quality assurance and evaluation and financing, and these are all components to really taking all components to think about when you think about taking a trauma-informed approach. As a reminder, we have incredible institutional resources here. So, you know, if you're sort of listening and thinking like, wow, you know, I'd like to think about how we do things differently in our clinical setting or in our division, you know, there are amazing resources here to support that. These are just the ones that were immediate in the first 3 seconds off the top of my head, but there's many more within our institution. But we have, very strong social work, psychiatry, psychology department. Many of our primary care clinics and specialty clinics have integrated mental health professionals. Human Resources has a great focus on workforce wellness and workplace wellness. The Child Health Advocacy Institute, through the work we're doing with the DC Collaborative on Mental Health and Primary Care, is really working to, help institutions and help divisions take a trauma-informed approach to the things that they're doing, and there's so many others across the hospital. So we really are an institution with a wealth of resources. We're starting in a very good place. Just as a kind of example of what can be done and some of what is happening, I will give a caveat, this is very early work, and so we're not very far along in it, but really starting to think about how in the Goldberg Centers we can start to develop a more trauma-informed system. We have Goldberg Center faculty partnering with our team from the DC Collaborative for Mental Health and Pediatric Primary Care, have formed a multidisciplinary team to really look deeper into this. And some of the things that this cross-division, cross-multidisciplinary team are doing are really thinking about how do we develop an educational plan for the centers, developing training modules that can be used by almost anyone, thinking about what are some of the high-impact strategies that we can implement within clinical settings. There's going to be things that require a lot of time and investment and resources, but there are also things that don't actually require huge amounts of time, investment, and resources and are really more a way of shifting approach. And so thinking about and recommending what those strategies should be. There is a lot of attention, particularly in primary care right now, about using screening tools and screening for trauma and adverse events in clinical settings and in primary care, particularly primary care settings. I will share my bias with that a little bit, which is that it is a very important piece of the strategy in thinking about how we address trauma, but that it can't be the only strategy in identifying and addressing adversity and trauma in clinical settings. And so part of what the team is doing is looking at potential screening tools and also recommending protocols, because the other side of this is that if you're going to ask about trauma, you should understand and know how you're going to respond when you get a positive answer. So it's not probably something that you just drop in without preparation. And then in some of our centers, starting at the new CHC Anacostia, but then also hopefully soon expanding to the ARC, we'll be piloting additional support staff whose primary goal is to really focus on family support in early childhood. We'll be piloting the embedding an early childhood mental health professional and family support worker to work with families in a more preventative way, meeting with them from the first well visit on and really talking with them about things like attachment and caregiving and development, and really providing a more proactive approach, and in the process identifying when patients and families have been exposed to trauma and what impact that's having on their ability to care for their kids at the moment. So lots of different things and ideas. I did run this by the team before I offered it, but if there are other clinics or divisions that are interested in talking to the team and learning about what they're doing and how they're doing it and looking at some of the research that they've been doing, we'd be happy to share that. Again, I know there are also, this is just one example, but there are other places in the hospital that are doing this as well and thinking about these things as well, and so I won't volunteer them because I didn't ask them first, but I suspect they would also be willing to talk and share. So then again, thinking about where you start in developing a trauma-informed approach to care, the first is raising awareness, which is something that can be done on a lot of different levels, and I think is really happening both within the field of pediatrics right now, but also within the local community and within the institution. A lot of that is already happening. Evaluating policies, thinking about an education and training plan, thinking about the environment. This is something I haven't really talked about. This is part of the report, but I haven't talked about that in detail. But the environment can have a huge impact on patients and families. So, kind of a small cluttered, dark, loud waiting room can be very activating. A calmer, quieter, there was a case study of an emergency room in Florida, and they took a trauma-informed approach, which led to actually a decrease in their use of seclusion and restraints. And actually one of the key things they did was repaint the walls and take down, they had a lot of sort of signs up that were not very encouraging signs. And so they took those down, rethought about the language that they used in their signage. And that was one of their key interventions, was repainting and putting new signs on the wall. And that was, and they had a decrease in the use of the, seclusion and restraints. And that wasn't the only thing they did, don't get me wrong, but thinking about the environment and how the environment can contribute as well. Really being thoughtful about workforce wellness and how that plays into all of this. And considering the use of a screening tool. As I said, screening tools can be very important. They can be very important tools. They shouldn't be the be-all and end-all, but they can be a very important tool in thinking about how you identify and approach families who have been exposed to trauma and adversity. And if you know that there's a family in your clinic who has a significant trauma history, you may think a little bit differently about how you and the staff interact with them and maybe help prevent escalation and agitation before it occurs. So with that, I know I've given a ton of information. Hopefully you don't feel like you've been drinking from a fire hose or jumped into a waterfall. But I'd like to close here and just give everyone a few opportunities, a few moments, and an opportunity for questions or comments.
Thank you so much, Lee. That was excellent. Very good. I wanted to, it's not so much a question directed at you, but to the group as a whole. You mentioned a lot of the areas of strength and a lot of the things that we're doing well, and I certainly agree with that. I also want to look at what else can we do, because we're challenged with this day in and day out, dealing with patients that we don't know what their life events have been, but clearly there's behavior that is difficult to manage. Right. So from your vantage point, and then I want to invite others to comment, what can we do? What are some, like Kathy would say, low-hanging fruit or fruit on the trees that we can really look at?
Yeah. So I think there's a couple things. I think that two key things. I think the education and training component is really, really important. And I think thinking about that, again, not just from the faculty side of things, but from, the first person at the front desk side of things. And I think that is an area where some of that has happened, but I don't know that we've been as deliberate about really incorporating the impact that trauma can have on patient and family behavior into our trainings. And so I think that that's one area. I think, and also I think being very deliberate and mindful. I think when this announcement that I was doing this grand rounds came out, I actually was contacted by a lot of people who said, I'm so glad you're doing this. I'm so glad you're saying this, because I am always hearing comments about patients when they're having difficult behaviors that are just not understanding of the experiences that they have had coming in, and some of that probably really comes from burnout and vicarious trauma and other things. Some of it probably comes from a lack of education and training. And so I was actually a little bit not surprised, but I was struck by the number of people who contacted me and said, I so often see patients who are having difficult behavior, and the comments that are happening from the staff and the comments that I'm hearing from the staff are just clearly tell me that there's not an understanding of the history that these patients have experienced. So I do think that's one important place to start. And I do also think this concept of workforce wellness is very important, because I think we can't be pushing this without at the same time being mindful of the impact that talking about these things and thinking about these things and addressing these things has on our patients, on our staff.
Lee, yeah, very, very nice talk. I worry a lot about the issue of scalability of this. I live in a variety of different worlds. I know almost all the traumas that my brain tumor population have, and I deal with that. Yet for the 5,000 odd kids who come in with chronic headaches, I haven't a clue, or even what I would do with them once I find out that they aren't sleeping at night, or that they're having parents are having marital problems. So what do you think about scalability of this approach? I really, it's a wonderful idea. It's good to have recognition. Yes, can we help a small group of patients one by one, but what about for the larger population?
No, I think it's a great question, and I almost think of it essentially within the public health framework where you have primary, secondary, and tertiary interventions. And I actually, from a scalability standpoint, I actually think the primary interventions are very doable because to some extent taking a trauma-informed approach is just helping staff and faculty be aware so that when they are managing or interacting with a patient who is having difficult behavior or unexplained medical complications, that they have an awareness that trauma may be playing a part of this. And that I actually think is pretty scalable. You know, that is really, that requires a deliberate approach to education and training, but it's pretty scalable. I think then you have to really think about within your clinical setting, sort of what are your resources and how are you going to respond? I think that is some of why I made my comments about the screening issue. I think that, you know, there are a lot of screens for trauma being advocated for and developed, and they can be very useful and helpful, but I do think those are, in those situations, you do really have to think about scalability and what your resources are to respond to that. And so I think there's sort of a layered approach. I think there's going to be clinical settings where there are high rates of trauma or the division really decides they want to go deeper and want to really address this in a more detailed way. And so I think it's a tiered approach, but I think that first layer, that primary prevention, is a pretty scalable thing just through raising awareness. And actually some of the, again, there's not a lot in the traditional literature about this. A lot of it has come from SAMHSA and kind of their experiences with organizations and looking at their organizational evaluations. But in organizations, even that level of intervention has changed, you know, the need for seclusion and restraint. So even that level of intervention does make a difference. I think the other piece is that there is an increasing movement towards integrating mental health care professionals into the clinical settings, and I think that's a really valuable component and a way to help the scalability of doing some of the more intensive interventions.
Any other questions for Dr. Beers? Dr. Rob? Got her.
Okay.
I'm just going to make that in the regular standard hospital history form, all those questions are there. Where do you live? Do you rent or own? Any financial concerns? Any major illness in the family? Do you live with somebody who smokes? Do you live with somebody who uses alcohol? Are there unlocked guns at home? Those are all questions we can all ask easily as we're doing an intake, whether that's your nurse practitioner or the physician or the PA doing it. And you can quickly look in the history, and it shows up when you print out your initial intake in the social history. So if you use your electronic medical record, all this stuff should be there. And that's helpful, especially if you're getting a consult on somebody you know nothing about, and they've pitched a fit in your waiting room because you're running behind schedule. Look quickly. It takes 2 seconds to click on the intake history.
I'm glad you mentioned that too. Actually, it reminds me of another, you know, so we've been looking at a lot of these different screening tools and kind of weighing the pluses and minuses, but there is one screening tool that is actually just a 2-question screening tool that focuses both on risk but also on strengths. And I'm going to paraphrase, I'm sure I won't get it exactly right, but the first question is, has anything worrisome or scary happened to you since the last time you came? And the second question is, what are the supports in your life that help you and support you? And it's just those simple 2 questions. We have a couple providers who've been sort of informally piloting those in our centers, and they have been amazingly shocked and surprised by the response they're getting from families. And most of them are saying, no, nothing's happened, but I'm so glad you asked that question. And so even that simple question can actually elicit a lot of information. So thank you for coming.
Any other questions? So, Lee, thank you so much.
Thank you.
It's been truly, truly informative and just really great in our whole summer series of how we're managing very complex population disorders. I also want to call out such a guest this year with Chair Savio,
thank you all. So our next series will be on July 27th at 8 o'clock. Dr. Diane Daly, special guest, coming in from Fort Worth, Texas, to talk about her impact and what she's done in the community and looking at the medical, or actually their medical. So, okay, thank you, everyone.